So I'll be starting off the session. I'll be talking about the basic clinical evaluation that you have to do in a patient with disc edema. I'll be mentioning almost all the findings, and as we proceed through the IC with the subsequent speakers, you will get to know how to streamline these findings to come to the right conclusion. I'm Dr. Deepa, Associate Professor of Ophthalmology, Government Medical College, Ernakulam. So starting with history, we should ask for headache, projectile vomiting, transient obscuration of vision, diplopia, defective vision, Uthoff's and Pulfric's phenomenon, which is usually seen associated with optic neuritis, scalp tenderness, jaw claudications, usually seen in AION, focal neurological deficits, fever, anorexia, arthralgia. Coming to the examination part, visual acuity, it can be normal or reduced. Sometimes it can be a sudden, profound visual loss which is progressing, associated with pain. The color vision may be normal or affected depending upon the cause for disc edema. The pupil can be normal. There can be a relative afferent pupillary defect or even an APD itself if it is a long-standing case. And on slit lamp examination, what we have to pointedly look for is whether there are any anterior vitreous cells. Fundus, again, we are looking for the findings in different conditions. You have to keep in mind papilledema. So in the early stages, you have to look for a blurred disc margins, hyperemic disc with absent spontaneous venous pulsations. If it is an established case, there will be dilated and tortuous veins, peripapillary patterns, lines, flame-shaped hemorrhages, hard exudates, cotton wool spots, a macular star or a fan. And in chronic cases, there will be a champagne cork appearance with obliterated cup, opticociliary shunts and retinal pigmentary changes. And atrophic stage shows a pale grey optic disc and narrow vessels with pigmentary changes. If it is a papillitis, mainly it will be a hyperemia with blurred margins, but the edema will be less compared to the papilledema where it was 3 to 6 diameters, it will be less than 3 diopters. Fewer hard exudates, dilated tortuous vessels, few hemorrhages and vitreous haze. Later, perivascular sheathing and obliteration of the cup may be seen. Retrobulbar neuritis may not have any finding. The fundus will be within normal limits. And in neuroretinitis, the papillitis features with hard exudates and macular fan may be seen. At AION will show a pallid disc edema with splinter hemorrhages, and in arthritic AION it will be a hyperemic disc edema, though diffuse, a segment of prominent involvement may be noted. Now, these are the basic things that we examine while doing a fundus evaluation. Other than that, there are some tests also that we have to do. The findings in each of these will be dealt with the subsequent speakers. So the tests that we have to do are HFA of fields, then fundus fluorescein angiography, neuroimaging to find out the cause, and a VEP to assess the functions of the optic nerve. Some systemic conditions that we have to keep in mind are malignant hypertension, Addison's disease, hypoparathyroidism, pregnancy-induced hypertension, and blood dyscrasias. The investigations: routine hemogram, ESR, CRP, MANDO, VDRL, ANA, toxoplasma, X-ray chest and PNS, MRI to look for space-occupying lesions or demyelinating changes, and idiopathic intracranial hypertension, VEP, CSF study, and look for NMO, anti-MOG antibodies. These are all what to go for, which to go for in which condition depends upon each case. So in the coming sessions, we'll see how to approach a case of